Excuse me. And I'd like to introduce Dr. Gigi Chen from Diablo Valley Oncology.
Good evening, and thank you for taking the time here to be here this evening. I also agree that lung cancer screening is so important for us to identify those early stage, patients, and so we can have much better cure rate for cancer, for the lung cancer. So I'm a medical oncologist, and now over the past few years, there has been tremendous advances in terms of chemotherapy treatments, targeted treatments. So this is actually a very, very exciting time for us, and I'd like to share some of those advances with you tonight. So again, lung cancer is a major public health problem. It affects many patients worldwide as well as in the United States. So there's 1.3 million deaths worldwide and 160,000 deaths in the United States. It's the #1 cause of cancer-related death in U.S. men and women. There's more death from lung cancer than breast, colon, prostate, liver, melanoma, and kidney cancer combined. So there's an urgent need for us to find better treatments for lung cancer. In terms of the anatomy of the lung, Dr. Strasnika had showed you a diagram here. So let's see. What we can see is that if this is an area of the lung cancer, the spread would be it can go to the regional lymph nodes and then go into the mediastinal lymph nodes, and then subsequently can travel to other sites of the body, such as the liver or the bone or other sites. So in terms of the lung cancer staging, the stage 1 lung cancer is that the cancer is only located in the lung and has not spread into the regional lymph nodes. Stage 2 is that the cancer is in the lung as well as in the nearby lymph nodes. Stage 3 is when the cancer is found in the lung and the lymph nodes in the middle of the chest, so it's also called locally advanced disease. And in the stage 3, there's the stage 3A and 3B. 3A means that the mediastinal lymph nodes are on the same side of the cancer. Stage 3B means it's on the opposite side. And stage 4 cancer is that the cancer has spread into either the bone, liver, or the fluid that surrounds the lung, called pleural effusion. So it used to be that the way we look at the lung cancer types would be the histology, meaning that if the pathologist look under a microscope, what does it look like? Does it form glands, or is it squamous? And so the non-small cell lung cancers are categorized into the adenocarcinoma, squamous cell cancer, large cell cancer, or sometimes they call it otherwise non-specified. The 85% of the lung cancers are non-small cell lung cancer, and 15% of the cancers are small cell lung cancer, and they're treated very differently. Okay. So for patients who are diagnosed with non-small cell lung cancer, which is the most common type, the treatments would include surgery and possibly chemotherapy, possibly radiation, or targeted therapy. And in the treatment of the small cell lung cancer, the treatments are usually, if the area fits into the same radiation port, we can treat with a combined chemotherapy and radiation rather than surgery. And if the disease is more extensive, then we would treat with chemotherapy alone. So when is radiation used? The radiation can be used if the tumor cannot be removed by surgery because its location or size, or if the patient's health is too poor to undergo surgery, or if the patients elect not to undergo surgery. After the surgery, for example, some of the stage 3, a patient with stage 3 disease, there are situations where we would use radiation after the surgery to get rid of the small deposits of the cancer. Or before the surgery, we use a combination of chemotherapy and radiation to shrink the cancer, and then after that, either a patient would undergo surgery or not undergo surgery. So those are the decisions where a group of physicians, including the surgeon, the medical oncologist, radiation oncologist, all get together and figure out what will be the best treatment plan for our patient. Radiation is also used to relieve the symptoms of advanced cancer, such as pain in the bone, or bleeding. So those would be the situations where we use radiation for palliation. And chemotherapy can be used either before the surgery to shrink the cancer, or used after the surgery to kill off any cancer cells that have been left behind. And it is the main treatment for patients who have advanced cancer, that's stage 4 cancer. So in 2013, 2014, there are many advances in lung cancer. And previously we had, in terms of the chemotherapy, most people, we use the same drugs. We use a platinum type of drug and then, pairs it with another drug. But now we first look at the histology. So we look at patients with squamous cell cancer versus non-squamous cell cancer. For people who have non-squamous cell cancer, we have drugs such as pemetrexed or Alemda or bevacizumab, which is Avastin, that are more for non-squamous type of cancer. And for squamous, we have things like gemcitabine or nab-paclitaxel, which we choose more for the squamous type of cancer. And we also look at biomarker-directed therapy, which is very exciting. So the cancers can have different mutations, and depending on the type of mutations, we can see, which are the targeted therapy that are more specific for these mutations, and patients can benefit dramatically from these therapy. And we're looking at patients who have had mutations in their cancer. We treat them with these specific drugs. Then over time, they can develop resistance. So we're studying, those resistance patterns as well, and developing drugs that are specific for those. So lots of choices, more decisions for patients when they're consulting with their physicians. So the use of the molecular profile is becoming more and more important in terms of selection for individual patients for the therapy. And we use this more in patients who had more advanced cancer, and that's how the new therapies are usually developed. We first start with patients who have advanced cancer, and then over time we test it more in patients who have earlier stage cancer. So if we look at, it used to be that all patients in the lung cancer look the same, when they come to the medical oncologist's office and we say, Mr. Smith, you have lung cancer, here's the chemotherapy drug we're going to use. But now we're understanding that in the 100 patients who have lung cancer, they can be quite different. The cancers can be quite different, so they can have different molecular profiles in which they'll benefit from very different therapy. So the important thing is to find out which patients among this 100 patients have a specific mutation, then we can have targeted therapies for them, versus the patient's cancer that does not have the mutation, then we would use the best available standard drugs. So in 2013, 2014, when a patient is diagnosed with lung cancer, advanced lung cancer, we now would send for specific molecular markers, specifically the EGFR mutation, which is about 15% of the patients, and also the EML-ALK rearrangement. And in some considerations, we also send for ROS. And the reason we send them off is because if a patient's cancer has these mutations, then we actually have oral therapy that can specifically target it. And these actually work better than chemotherapy. So what we do is that we can do the different stains or the fish for these mutations, and as a result we have different medicines for patients who have different mutations. It's called personalized medicine. So one of the area is something called EGFR inhibitors, which is the EGFR is epidermal growth factor receptor, and that's one of the mechanisms of a driver mutation in lung cancer. So if this gene is turned on, then it can cause proliferation of the lung cancer. So what we can do is we can have specific drugs that target this type of receptor, so we can block the growth of the lung cancer. And the common drugs that are used, that are FDA approved, including 3 different types of medication. One is gefitinib, which is actually used more internationally, not approved in the United States. erlotinib, which is Tarceva, and also afatinib, which is Geotrope. All three are used in patients who have EGFR mutation positivity. So again, this is a type of mutation that's found in 10 to 15% of the patients who have lung cancer. And traditionally, we found it more in never smokers, in Asians, females, and adenocarcinomas. We also know that they have specific types, the EGFR deletion 19 or L58R. Now, some of the patients have more resistant mutations, which we're finding out that they have the T790M, and there are many actually clinical trials that are ongoing that are specifically targeting that, which is very exciting. So this was one of the trials, which was the LUX-Lung-3 trial, which looked at comparing one of the EGFR inhibitors, which is afatinib, to the chemotherapy. And what we actually find is that the oral drug, in terms of the response rate, works better than the chemotherapy. So, and they're in general lesser toxic. So these are very exciting information. The other type of mutation is ALK rearrangement, and that only occurs in about 5 to 7% of the populations in patients with lung cancer. But the exciting thing is that there's a oral medication, which is crizotinib, that was initially found in 2005, but went through many years of development, and now has been approved for patients who have non-small cell lung cancer who have this mutation. And you can see this is a plot indicating the patients who are responding to the drug, and then the percentage of in terms of the cancer reduction by the drug. So that's actually very, very exciting. Again, what we see is that comparing to the chemotherapy, the oral medication works a lot better. This is a line for what we call progression-free survival. So the higher the line, the better the patients are doing. Okay. And here is a picture of a CAT scan of a patient or a PET scan of a patient. You can see that there is quite a bit of cancer here, and this is after one cycle of the oral targeted agents. You can see that the cancer essentially, most of it goes away. So these are very, very exciting. Okay. And there are also second-line ALK inhibitors, which the LDK378 was also approved, for patients who have the ALK rearrangement, and many more that are under development and under research. Okay. So again, by these strategies, what we're hoping to find is selecting patients out who have these driver mutations and treat the patients with specific targeted agents. Now for the rest of our patients, the majority of patients, that they may not harbor these mutations, so what we would use is standard chemotherapy. And one of the strategies we use was a combination of the chemotherapy plus bevacizumab, the Avastin, which is a monoclonal antibody. And what it does is that it limits the blood supply to the tumor, so therefore be able to shrink, the tumor by limiting their blood supply, their oxygens. And then in general, patients, if they have advanced lung cancer, they would be treated for about 4 to 6 cycles of the chemotherapy. And after that, we have the strategies of either watch or consideration for something called maintenance chemotherapy to trying to keep the cancer away for as long as possible. So there have been studies looking at either continuation maintenance using the same chemotherapy drug, but use one instead of the two. So Alimta maintenance has been used as a common strategy, or a switch maintenance, meaning switch to a different type of a drug and then use that as maintenance therapy. The maintenance therapy have shown, increased survival, for our patients. So for patients who can tolerate it, we're using that increasingly commonly. And now there are, after a course of the therapy, patient will progress, meaning that the cancer is going to grow bigger. And there are chemotherapy drugs or targeted agents that have been approved as second-line agents, and we can use those. There are also multiple investigation options, and one of them is called PD1 or PD-L1 targeted immunotherapy. What that involves, it's actually becoming the immunotherapy in lung cancer is becoming a very exciting field. And what that involves is that, the tumor cells and our cells, they can have the PD-1, PD-L1 interaction, and that can depress, our own immune system to target cancer. So by targeting these PD-1, PD-L1 ligands, what it does is that, we can increase our T cell, our own immune surveillance to target the cancer cells. So it's being studied in multiple clinical trials, and there are many lead agents that are showing very promising results. So I think the immunotherapy is going to become a very, we're going to have drugs approved shortly, and that's going to become a very exciting field over the next couple of years. So these are just some of the drugs that are under investigation, for the PD-1, PD-L1, the immune checkpoint studies for patients who have advanced cancer. Okay. There are also vaccine trial, which is another type of immunotherapy that's being looked at in lung cancer. So theoretically, if we can have a vaccine, to prevent the cancer, that will be something that has a lesser toxicity and, hopefully a durable response. So that's also being investigated. The side effects of the traditional chemotherapy, as many of you know, includes hair loss, some nausea, vomiting, diarrhea, gastrointestinal symptoms, increased risk for infection, fatigue, neuropathy. I think we have better ways in terms of managing these side effects, but these side effects do exist. And at the completion of the treatment, it's very important to continue with follow-up appointments. And we usually screen patients on the course of every 6 to 12 months for the first 2 years, and then yearly CT scan after that. Certainly, we ask our patients to maintain a very healthy lifestyle, exercise, stay away from tobacco. So I think the cancer treatment in the future would be, we're going to know the molecular sequences for the cancer much better, and then we can come to our doctor and say, oh, here's my sequence and what's the best therapy for me, right? In individualized medicine here. So I think this is a very exciting field, and thank you for being here today.